Good afternoon, everyone. I'm taking you through this presentation, and it will basically concentrate on the following. Firstly, a rationale for why we're saying at this point in time we need a strategy refinement. Also, our targeted hotspot plan, then providing data at town and suburb level, and then to update you on the health system preparedness, and with some concluding remarks. This presentation is shared between myself, Mr. Harry Malila, who is the DG for the province, and Dr. Melvin Woodley, who is working in the Department of Health. So the strategy refinement, this is just a reminder for people in terms of the picture in the Western Cape. To the left bottom is Professor Abdul Karim's slide on the 13th of April, where he indicated that local imported cases, which is the blue graph, import associated, which is the red graph, by and large with the lockdown in this country was contained. And that the green graph, which is what is called local transmission, was slow in uptake in the country. The reality in the Western Cape is the left top graph, is that local transmission was seeded in the Western Cape during that period. So as of the 13th of April, 14th of April, we started seeing evidence of local transmission in the Western Cape, and that is the graph that started growing. So it is the increase of the graph. It was not the lower graph that the rest of the country was experiencing. We had our uptake during that period. So we are saying in this province, we are earlier than the rest of the country, but we've not seen any evidence that there is anything different that will happen from this province to other provinces. It is just that we're earlier in that uptake. So that's the first slide. Oops. A little bit more about these clusters that I mentioned. We've now got a very detailed database about these clusters, and most of the cases we saw was in retail and driven by specific supermarket chains. We have the name of each supermarket, we have the number of cases we detected in each one, followed by law enforcement. So there's quite a few police stations that's been affected, and we're working very closely with SAPS and law enforcement from the city because there's clusters in those workplaces. The pharmaceutical company that you're all aware of, that we've discussed at earlier places, and then the retirement and old age homes, and then a range of other facilities, including correctional services. And interestingly, in correctional services, that cluster gave rise to the number of cases we saw in Witzenberg. But these are the clusters that started community transmission in our province. And then the transmission in local communities. These are all the people in those clusters, their address of residence. So you'll see the majority of the people that were in those clusters lives in Khayelitsha, followed by the Tygerberg sub-district, followed by Western, followed by Eastern, Mitchell's Plain, etc. And that is where the local community transmission had its root and started establishing itself in those communities. So the current status of the epidemic in the Cape Metro, we have a rapidly increasing epidemic with increases in hospitalization and in deaths. The Premier has referred to the fact that we've gone over 200 deaths. We are on the upward part of the curve, which is the nature of the pandemic. So we're truly in the uptake of the epidemic phase in the Western Cape, specifically in the Cape Metro. There is concentrated in these clusters that I just spoke about, care homes, and in the geographic areas where the workers live, which I illustrated to you, which is mostly in the most vulnerable communities in Cape Town. So our hotspot intervention, therefore, is prioritized in these geographic areas. At the same time, our testing and our lab capacity is under severe strain. And there's been very well documented over the last two weeks, the big backlog that we're experiencing not only in the state laboratory service, but also in the private sector laboratory service. The facilities to isolate and quarantine offsite are being scaled up. We're bringing more and more facilities online, but the limits of this available capacity will ultimately be exceeded. There are a large number of undetected cases, which will continue to grow because of the limitations of testing. So as we have found more and more tests, more positive cases, there are more and more positive cases. But because testing is a limitation, we will not be keeping up detecting all the new cases as they grow. That's also not unique to our situation. It has been repeated elsewhere in the world. The ability to continue with individual case detection and contact tracing is therefore being stretched by the sheer numbers of new positive cases and their contacts. If you look at the current status in rural districts, it is a slightly different picture. The Cape Winelands district is showing evidence of multiple clusters and faster spread, having started in Witzenberg 3 weeks ago, and it's now moving on to Drakensberg, Stellenbosch, and Brede Valley in the past 2 weeks. So there is emerging clusters, and it would probably be fair to say that Cape Winelands in many places are similar to where Cape Metro was 4 weeks ago in terms of these emerging clusters. There's also earlier clusters in Overberg, in Theewaterskloof, Swellendam, and in West Coast in Swartland during the past week, while there's still many areas with no cases or only very limited cases, or cases that was completely have recovered in the rest of the province. So it's not the same picture everywhere in the province. The testing and lab capacity strain is impacting on these rural areas to detect cases earlier and to move to isolation and quarantine, because it's still a very effective intervention, but they are also hamstrung by the same testing and lab capacity strain. The ability to isolate and quarantine offsite will be scaled up rapidly across all the rural areas, and our Department of Public Works is bringing that online together with municipalities very quickly. There's projected to be a smaller number of undetected cases, and therefore aggressive testing is still indicated in the rural districts. And there's still very big value in individual case detection and contact tracing to contain the spread in those specific areas. But let's come back to the Cape Metro. The fundamental issue we want to put on the table is to say that we propose something called a risk-stratified case management approach. And it is at this point in time that we're saying we want to turn our attention to the most vulnerable people. And I will explain the definition of vulnerability, because we're saying now we want to take a dedicated focus to find the most vulnerable people. And if I go into this, we're basically saying of all cases, we really want to get into the mode that people that are generally going to contract COVID, that become symptomatic, needs to know when to seek help, but also needs to know how to self-isolate and how to manage their own symptoms, because by and large, 90% of people will recover. But also of all our known cases, the ones that we've diagnosed, many of them are at lower risk. And again, we can give them the advice, self-isolate, self-medicate. If you need advice, call us and we will help you through how to do that. But then we come out of the known cases, there's this group that is red there. Those are people that by us, we're giving them a higher risk rating. And I'll explain why we're giving them a higher risk rating. It is all to do with what's living in the graph, and the next slide is this graph. But we're saying that our health system should actually manage these higher risk cases with greater attention. It is looking after the vulnerable, making sure that they are safe, and putting our energies and efforts into them, because they're the likely group of people that is likely to be iller if they get COVID and land up in a hospital that might require them to land up in an intensive care unit. And obviously then there's a group of people that's not known to us. And therefore we want to also target our finding of cases more towards this unknown part of the high-risk group, so we know them earlier and work with them better. So if I can go to the next slide, This is an analysis of 1,942 cases over a 7-day period from midpoint in this week. So we looked back, and in that we looked at that cases, and we found that 66% of those cases, 1,273, are under the age of 55, and they have no comorbidity. That means they have no diabetes, hypertension, or anything that puts them at risk. So in a sense, we can say 2/3 of all our new cases are in a relatively lower risk group for any complication. And the likelihood of this group, the likely outcome for them, is all of them will recover within the space of 2 weeks and will have very little symptoms or negative impact of COVID. On the other hand, 19% of those cases was under the age of 55, and they had comorbidities. So they had hypertension, they had diabetes, and HIV, obesity, and a range of other lung disease and those kind of comorbidities. They are at a higher risk than this group. And I'll come back to this higher risk, because if you look at how many people come to our hospitals, this is the group. Out of this group, people become more ill, and they're the ones that present to hospital, and they therefore are higher risk. Then there is 9% of people that's over the age of 55 with no comorbidity, but we also know the age differential of 55. Somehow there's higher risk just being over 55. And then the highest risk group is the ones over 55 with comorbidity. So our strategy is, our focus should be on this 1/3 of all cases, and the people that is not detected in our society, because they are the vulnerable ones. So we really want to move towards protecting the vulnerable. So the proposal for the strategy alignment in the Cape Metro is, we streamline our testing and our contact tracing activities to focus on high-risk groups such as health workers and vulnerable people. Testing for health workers, tracing and screening for vulnerable people. We emphasize that case management with a view to early detection of deterioration in health status through this risk stratification is what we want to do. So it's really finding everybody that's over 55 with or without comorbidity, and people under 55 with a comorbidity, and focusing on that group of people to make sure that we could detect very quickly whether their condition deteriorates and put special attention on them. We also want to increase focus on mass communication and building agency for behavior change. The big thrust of all of what we want to do is still that individuals and organizations across all sectors need to have behavior change, to observe social distancing, to make sure that the transmission is broken. Then repurpose what we're doing with community screening and testing and community health workers towards the vulnerable persons. And then strengthen the workplace and institutional agency with a focus for preventing things in workplaces. So the CST then focus on reaching high-risk groups, such as the elderly and those with known comorbidities. And at the same time, what is very important is that the health system starts focusing on being prepared. Because as we have more cases, more vulnerable people will come to hospitals. More of them have to be investigated for COVID. So other than saying we have a priority for testing health workers, we're then also saying for the people that come into the health facility, which is likely to be from this vulnerable group, that we also want to have testing prioritized for them. And that we then use that testing and we prepare the healthcare system for the cases that comes into hospitals. So what does it mean for our hotspot strategy? We want this health strategy to be aligned to this case management approach in these areas of community and transmission. We want to identify appropriate people for admission to designated isolation and quarantine facilities. This will have to be nuanced in light of our testing challenges, but also together with exploring viable and maybe feasible community isolation options via community initiatives. But the big thing we're saying is we will still have quarantine and isolation. It is when we go to the vulnerable person's home to decide who is the most appropriate people that should be in isolation and quarantine. with the sole purpose of protecting the most vulnerable people. So we also need this nuanced, agile, proactive, and adaptive response in local community spaces. And that is to have almost a zero tolerance for not observing social distancing. Find all the areas of gathering. Have universal cloth masks and really have hygiene and surface hygiene. We still have a chance to break transmission if we all do it in that concerted way. And then the rate of increase of transmission rates per ward and suburb would be tracked over the next 6 to 8 weeks. It's just a health platform preparedness. So the first one is the primary care system. And the principle here is that we're strengthening the primary care system where the clinics and the community health centers are, because 90% of cases will be relatively wild and be managed via this platform. Therefore, they need to be COVID responsive, but we also need to maintain essential services like immunizations, management of chronic diseases, continued management of HIV, TB, and appropriate maternal and child health services. And preparedness plans is to make sure that this platform functions effectively. So the kind of things we're looking at is staff training for IPC and the use of PPE, staff screening at facilities, and then staff support. But also the supply chain to make sure there's enough stocks, there's enough oxygen, system to collect contaminated waste, and then infrastructure issues to reorganize these primary care facilities to be able to manage COVID and non-COVID patients, because we cannot not maintain some of the services that's essential outside of COVID. And facilities will be prioritized according to greatest need. And we need to continue data, and we need to work on a very smart communication set of tools. We're very fortunate to work with many partners, and the UCT's Knowledge Translation Unit is working very closely with us with appropriate materials in this regard. Then the big area is the acute care and critical care and palliative care area. This is where our hospitals that will become under pressure, where we need to say, what do we do to plan for that? As previously announced by the Premier, we are planning for field hospitals. We are planning for up to 1,428 beds. CTICC will be 850 of that. Bracken Gate on the R300 will be 330. Tusong Centre in Khayelitsha 68. And in Soonstraal will be 150. And Tygerberg Hospital will have 30 additional beds. The acute beds for moderate cases, this is our own existing public sector beds. We want to free up 2,162 beds from within our existing capacity, of which 658 are additional beds through expansion. So this, just to explain to you, is across all our public hospitals. By clearing the space or opening the beds, we will create a capacity of 2,162 beds. Then is the big issue of critical care. We have existing 150 beds in the public sector. We will bring online another additional 100 beds, but it requires additional resources, and we're planning and putting it in. Then the public sector, which wishes to purchase from the private sector. So we will also purchase 300 beds from the private sector for public sector patients. And then the last one is the private sector themselves. We're projecting to use 300 beds for critical care. Then the last one that we are talking about here is palliative care. It is also to look at the inpatient and the community model for palliative care. And 695 beds are planned for the peak, with some additional palliative care overflow of 75 standalone beds in the system. So that's a subtotal of what we're planning for bed capacity. This is just a very rapid update of what we call test and triage temporary structures. We have brought online 17 places or 16 places already. And the Red Cross and Ceres is coming online. It's completed. It just needs to be brought online. And then it's Grootske and Mowbray that still will come online. We're also planning some additional facilities now to expand it, and that's what we call phase 2. And we are progressing to confirm those so that we can move on to that. This is just a more detailed update on Tusong Centre. It is donated and implemented by Doctors Without Borders, MSF, and we're working with them. And MSF staff will be staffing it, and it's anticipated by the 30th of June 30th of May, they will be on site. Convention Center, we are on track. The construction is going well. We are projecting that by the 8th of June, we should be able to admit people. Brackengate, we are in the design phase. Our lease agreement is currently with Provincial Treasury. The facility can accommodate 330 beds. We will bring this online, and we are hoping to bring it faster than the 7th of July, but that's what our outer limit of delivery is. Tygerberg Hospital, we will take that temporary structure there and turn it into 30 more beds, ready for July. And in Soonstraal, which is outside Paarl, construction is underway. We're bringing 63 beds by the beginning of June, and then we bring the additional beds in after that. So in conclusion, we shared with you a refined strategy is required to deal with the different realities of both metro and rural. The risk-stratified case management is an important strategy refinement to adopt in these areas of established community transmission. Our local teams will then work through established community transmission to focus on reducing morbidity and mortality by focusing on the most vulnerable. Behavior change through all of government, all of society should be nuanced, and it's the thrust of what we want to do over the next 6 to 8 weeks. And the health system should focus on making itself ready and using testing sparingly and appropriately in the clinic environment. Thank you very much.